Cek cek. Cek cek cek. Cek cek. Cek 1 2. Cek cek 1 2. Cek.
This video. Exploring the abdominal.
Udah cantik, udah cantik. Good morning everyone. Annyeonghaseyo. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Our distinguished guests, respected speakers, doctors, healthcare professionals who join us in this room and virtually. Allow me to conduct today's symposium in English. On behalf of Muni Teguh Memorial Hospital, it is my pleasure to welcome all of you to today's mini symposium about modern approaches in laparoscopic colorectal surgery. First and foremost, let us express our deepest gratitude to Almighty God for His grace and blessings which have made it possible for us to gather here today, both on-site and online. A very warm welcome to all participants joining us in the auditorium as well as those attending virtually. My name is Dr. Widya Panduwinata, and it is my pleasure to serve as your Master of Ceremony for today's mini symposium. We are especially honored to welcome Dr. Mutiara MH MKT DABLM as our President Director of PT Munisada Tbk, Dr. Tuan Junior Situmorang MKS Director of Muni Teguh Memorial Hospital and the Board of the Directors, and we are especially honored to welcome our distinguished guest, international expert, Professor Dr. Kim Son Han, as a professor and consultant colorectal surgeon who has extensive experience and remarkable contribution in the field of the colorectal surgery. Welcome to Muni Teguh Memorial Hospital, Prof. And our speakers, another speaker is Dr. Yasin Leonardi, consultant digestive surgeon and as our beloved doctor in Muni Teguh Memorial Hospital. And we welcome Dr. Adrian Wong, clinical specialist from H Medical Shenzhen. Today's mini symposium aims to deepen our understanding of the latest development and practical approaches in laparoscopic colorectal surgery, particularly focusing on complete mesosolic excision, or CME, and total mesorectal excision, TME, which have become important standards in achieving better surgical outcomes. We hope today's scientific discussion will inspire all participants and contribute to improving the quality of surgical care for our patients. To officially open today's symposium, it is our great honor to invite the President Director of PT Munisada Tbk to deliver the welcoming remarks. Please welcome Dr. Mutiara.
Selamat pagi, salam sejahtera untuk kita semua. Yang saya hormati, we welcome you, Profesor Dr. Kim Sun Han dan Dr. Adrian Wong dan juga pembicara kita Dr. Yasin. Hari ini adalah hari yang bahagia sehingga kita mempunyai kesempatan bersama-sama mengadakan simposium pada pagi hari ini. Kita benar-benar ada kesempatan begitu indah bisa mendapatkan Profesor Kim menjadi pembicara di sini. Tidak mudah mengundang dia ya. Dan juga kita terima kasih ke Dr. Adrian yang sudah meluangkan waktu di sini sehingga kita mengharapkan acara hari ini bisa lebih baik lagi. Kita tahu bahwa approach surgery daripada colorectal itu sangat penting. Di dunia ini menurut Global tahun 2024 ada 2 juta orang pasien baru daripada CA colorectal yang terjadi. Dan di antara itu ada 917.000 yang meninggal. Juga di Indonesia tercatat 39.000 kasus baru per tahun di tahun 2024 dan ada 18.878 orang yang meninggal. Angka ini menunjukkan sesuatu yang sangat tinggi dan merupakan angka kematian dan angka kesakitan nomor 3 kanker di seluruh dunia atau di Indonesia juga. Jika kita mempunyai suatu cara pengoperasian yang cukup canggih dan bagus, yakin maka hasil kita akan jauh lebih bagus. Dan kita mengharapkan melalui simposium ini akan membawa suatu dampak yang positif untuk semua dokter-dokter bedah, sehingga kita mempunyai suatu teknik yang lebih maju lagi. Ya, Muni Teguh selalu hadir untuk bersama-sama, kita bersama-sama bagaimana tuh meningkatkan kapabilitas daripada dokter kita. Kalau jika berminat, joinlah Muni Teguh, maka kita bersama-sama berkembang, mengharapkan pasien kanker di Kota Medan dan sekitarnya mempunyai suatu solusi yang baik. Untuk berikutnya saya nggak panjang lebar, saya hanya ingin mengharapkan bahwa acara ini membawa makna untuk kita. Marilah bisa bergandengan tangan bersama-sama mensupport pasien-pasien yang menderita dan memberi solusi yang baik dan penanganan yang maksimal. Terima kasih.
Thank you very much, Dr. Mutiara, for the inspiring opening remarks. And now it is our pleasure to invite our distinguished international guest speaker, Professor Kim Son Han, to deliver his welcoming remarks. Professor, the floor is yours.
안녕하세요. Apa kabar?
Baik.
I'm really happy, number one, to see Dr. Yashin. I met him first about 12, 13 years ago in Singapore. I was a visiting professor for the 6 years period of time. Every 2 months I visited National University Hospital to teach and proctor the robotic surgeries in particular. At the time I met him. He was a clinical fellow. Then I'm very proud of him that he is doing here in a very important colorectal specialist. And also very honored to visit this Murni Tegu Memorial Hospital. I read a very short article about this hospital. Very impressive why the family established this hospital and what the hospital is now doing for your society. I'm very honored to come here. Thank you for the invitation, and also thank you for this very special opportunity. Today is not like an ordinary formal society congress symposium. It's mini symposium, but I know many of you here want to learn something more in detail for your own practice. So I will do my best for your purpose today. Thank you very much again.
Thank you very much, Professor, for your warm and inspiring words. And ladies and gentlemen, before we begin today's scientific session, we are pleased to present a short robotic colorectal surgery procedure video, which is demonstrating the advancement of minimally invasive surgical technology in colorectal surgery. Please enjoy the presentation. Please give applause for our robotic operation. And now we begin our first scientific session. Our first topic is entitled Anatomy for Complete Mesocolic Excision, CME, and Total Mesorectal Excision, TME. It is my pleasure to invite Dr. Yasin Leonardi to deliver his presentation. Doctor, the floor is yours.
Selamat pagi kepada Dr. Mutiara, selaku Presiden Direktur Murid Teguh. Good morning to our distinguished speaker, Prof. Kim Seong-han, who is willing to share his expertise to us. Actually, I'm still learning. I was asked to talk about anatomy for and total mesocolic excision. Okay. Maybe I talk in Indonesian language. The purpose of tujuan utama operasi CME atau TME itu pertama supaya preservasi mesokolik atau mesorektal fascia, kemudian high central vascular ligation. Jadi supaya fascianya utuh, kita harus tahu mengenai anatomi. Jadi pengetahuan anatomi yang baik akan memberikan hasil approach yang lebih baik. Jadi ini ada 3 hasil output dari operasi. Pertama, diseksi sepanjang fascia mesokolik, yaitu yang mesokolik plane. Kemudian terjadi breaching dari mesokolik plane, jadi masuk ke mesokolik, dan yang ketiga masuk ke muscularis propria. Jadi pada saat embrio terjadi rotasi dari kolon, sehingga kolon itu berputar counterclockwise sehingga melekat ke retroperitoneal. Jadi terjadi fiksasi dari kolon. Ini kolon kiri berputar melekat ke retroperitoneal. Terjadi fusi dari fascia, fusi antara mesokolon descendant dengan retroperitoneal, ini disebut fusi fascia retol. Jadi approach nanti akan diterangkan Prof. Kim, bisa dari belakang atau di intrafascia. Jadi sesudah terjadi rotasi, kolon kanan melekat ke retroperitoneal, terjadi fusi antara kolon dengan retroperitoneal. Di sini fusi fascia retol, kemudian di duodenum pankreas terjadi fusi antara mesokolon dengan duodenum pankreas, fusi di sini fusi fascia Fredet dan Trach. Jadi posisi ureter dan gonadal vessel di belakang fascia ini. Ini fascia jadi kolon, mesokolon, kemudian ada fascia peritoneum parietal. Dia sesudah fascia peritoneum parietal, fascia renalis di belakangnya, baru di dalam fascia renalis baru terdapat ureter dan gonadal vessel. Cannot move. Nggak bisa. Oh udah, bisa. Oh, ya. Ini vascular anatomy dari untuk CME. Jadi dari arteri mesenterika superior, jadi ada arteri iliokolika di cabang. Ya, jadi yang ini aorta, ini arteri mesenterika superior yang selalu ada itu arteri iliokolika. Kemudian arteri kolika media, kadang-kadang terdapat arteri kolika dextra. Untuk yang sebelah kiri, arteri mesenterika inferior, dia ke atas ke arteri kolika sinistra, ke bawah arteri sigmoidalis dan arteri rectalis superior. Antara dua pembuluh darah ini ada hubungan. Di sini area vena mesenterika superior. Jadi ini vena iliokolika, vena kolika dextra, trunkus Henle. Jadi antara vena iliokolika dengan trunkus Henle itu jaraknya kira-kira 4 sampai 44 mili lah kita. Trunkus Henle ini menerima darah dari vena kolika dextra, vena gastroepiploica. Kemudian ini sesudah rotasi, fiksasi antara ascending colon dengan retroperitoneal terdapat fusi dari fusi antara kolon ascendent dengan retroperitoneal di sini trach. Di belakang pankreas dengan duodenum terdapat fascia pankreatica posterior, fascia pankreatica anterior. Di sini trach. Jadi pada CME kanan pembebasan dari mengikuti fascia tol, kemudian di daerah flexura hepatica. Di sini ada mesokolon transversum, kemudian ada omentum. Omentum itu ada 4 lapis, jadi fusi fascia antara mesokolon dengan lapisan keempat dari omentum. Di sini pankreas, ini mesokolon. Kemudian ini lapisan keempat dari omentum. Ini untuk kolon kiri, trach, fascia dari tol. Jadi plane-nya antara mesenterika inferior dengan plexus hypogastrius di belakang plane ini. Untuk rektum, jadi di sini mesorektal, kemudian ada fascia propria mesorekti, kemudian fascia presakral. Di belakang fascia presakral ada nervus, ada pembuluh darah, kemudian ada fascia adenoinferior, lanjutan dari fascia presaklar, gallbladder, vesicula seminalis. Untuk sagittal, jadi ini fascia rektal propria, Kemudian ini fascia presakral, diseksinya di daerah sini nanti akan diterangkan. Kemudian di sini fascia adenoinferior. Kemudian antara fascia dari fascia propria recti dengan fascia presakral akan menyatu. Rectosacral fascia, fascia Waldeyer. Ini yang dari atas, rongga panggul, pelvic floor, anal hiatus, urogenital hiatus, otot pubo rectalis, pubo coccygeus, dan levator ani. Levator ani. Sphincter externa, sphincter interna. Kemudian mesokolon sama mesorektum itu satu kesatuan. Jadi dibatasi oleh fascia subperitoneal profunda, kemudian superficial di sini mesorektum. Ini fascia mesorektum, ini fascia subperitoneal profunda, fascia adenoinferior. Oke, thank you.
Okay,
Mungkin
thank you.
Prof. Ya,
Thank you, Dr. Yasin, for the excellent presentation. We now continue with our second scientific session. Our distinguished speaker, Professor Kim Son Han, will present tips and tricks in complete mesocolic excision CMA, and the third is tips and tricks in total mesorectal excision. Professor, please.
Again, thank you, Dr. Mutiara, Dr. Jongkai, and Mr. Chian, if he is not here. And thank you very much for joining this morning mini symposium. I know very well, if you see all the complicated figures about anatomy, you get more confused. But don't worry, my talk today is mostly videos. You can get a slightly better idea. And just for your reference, the video you saw at the beginning was the robotic low entry resection done yesterday, and the video shown today is the very initial part of the procedure, that is IMV high ligation and lesser sac entering to separate the pancreas down to do complete splenic flexure mobilization. You will see my videos as well. Today I have two talks, TME and CME. I would like to start with TME first, because this tells a little more about the principle of my laparoscopic maneuvers. I think it is better to move forward. Next slide, please. Yes. This is my steps of low entry section, dividing the mesenteric vessels, IMA and IMV. Nowadays, I prefer IMV first approach, or lesser sac first approach. Then dissection of the left colon mesentery, medial to lateral. Then full splenic flexion mobilization and dissection of the rectum and transection of the rectum by a linear cutter, and double stapling technique is my standard for anastomosis, And of course, we need diverting stoma selectively. This is very important. So during whole my talk afterward, focus on this. This is my principle. This is my key technical teaching point to my current fellows, resident in Korea in the past, now in Malaysia. Two hands free technique. That means I'm trying to move my two hands free as much as possible. In other words, for example, if I am holding one structure with my hand, non-dominant hand, that is my left hand, because I am right-hand person, my surgery is doing one-hand surgery. For me, it's a kind of a handicapped surgery, because I have two hands. Why I'm doing surgery with one hand? So two hands free technique, very important. To have this, the essential part is I have to utilize my own assistant. Otherwise, I cannot get my two hands free. Very important. And dry gauze. Next. And also, the final exposure of the operating field is depending on the surgeon's non-dominant hand. It's not your assistant's responsibility. It's surgeon's duty. You can see what I am trying to tell today through the following videos. Next. 5 trocar technique is my standard for cancer operation. 4 quadrant, scope in the midline. Then, can you click the right side video? Trendelenburg position, right side down. Okay. Initial exposure, very important. If your initial exposure is not done well, the entire procedure will be very difficult. I saw many times during live surgeries, other surgeons' operation, they don't do this. So when I'm watching their operations, not good. Because still small bowels are there. Very difficult. But once I have this much exposure, yeah. Monopolar, bipolar, no, it's laparoscope, sorry. 2 hands free. Now assistant is holding the vascular pedicle. 2 hands free. This is 2 hand free technique. Assistant is, look at this, giving me exposure if needed, big lymph node, traction, counter traction, aorta, IMA, this is how I can get my left hand free now. My assistant holding, then I can utilize my left hand. Next. Next. This is a very recent video done in University Malaya Medical Center. Here, my fellow had difficulty to expose this area. So I am demonstrating how we can get a good exposure. Gauze and my assistant is keep this And here, one hand, the other hand is somewhere here. Next. Next. So this is my current technique. IMV and laser sec first approach. Once I divide IMV, lifting up the transverse mesentery, anteriorward, upward. Then assistant, left hand, assistant, right hand. I am having my two hands free. So already laser sac. Good traction on the mesentery is the key to avoid any wrong plane. Laser sac. But this particular patient has arc of Riolan. I have a couple of, this is one of my one of my research during the last 5 years. This is very important artery to preserve the colonic perfusion after anastomosis. So once I see it, I preserve it. Very important. About 20% of patients, Korean, Australian, even Malaysian, same. About 15 to 20% has this artery. There is arc of Riolan. You have to preserve once you see it. Right side, click. Same thing here. IMV. Then look at this. Here, once I lifting up this transverse mesocolon, mesentery is mobile organ. Pancreas is fixed organ. Because of that, there is always groove. There is pancreatico-mesocolonic groove. So once you see it, just cut the peritoneum 1 or 2 centimeter above the groove, then you enter the laser sac. Once you learn this technique, the splenic flexion mobilization is quite easy, I would say. My fellows, after 1 month, 2 months, they learn this technique. It's already laser sac, pancreas head, body, transverse mesocolon, IMV. If you go here, it's wrong plane. Why? This is the gerotas fascia. Later on, I will tell you. This is one of a common error. If you follow this, always go below the pancreas. Because this is anatomy. So once I open this, just connect these two areas, that is the plane. Next. Next, please. Exactly same for my robotic. Because all techniques, what I'm utilizing during robotic came from my laparoscopic procedure. Look at this. Here, mobile, fixed, groove, cut. That's it. That was exactly the case yesterday. You saw this part at the beginning. This at the beginning, I thought that was the IMV, but the IMV was just ligated now. But the advantage of robot is I can get better exposure using my third arm, own third arm. Third arm is another robotic arm. Look at this. Here, good traction on the mesentery is the key. This is pancreas. Now I'm see spleen. Very often I see spleen from medial side. Not many surgeons you saw spleen from medial side. So whenever surgeons watch this operation, they told me, this is first time to see spleen from the below. That's true. Okay, next. Next, please. So the potential benefit of this approach is this. If you just do in this way without lesser sac entering, always go below. Then you will meet a big vein, that is a splenic vein. But once we open this space at the beginning, this is the way to go. Very important anatomy. Next. Next, please. And also, once I dissected off the pancreas during the lateral dissection, is almost zero risk of injury to the pancreas or even spleen. This is the benefit of that approach. Next. Another video. So you may recognize my laparoscopic video is a little old because during the last 5-10 years, all my video is robotic. So I don't have much the recent laparoscopic videos. It's old, but as you see, everything is same. It's quite well established. Almost every step is standardized, optimized. So my current technique is exactly the same. Medial to lateral. Look at this. My two hands are always free. How? Because I'm utilizing my assistant. This is one simple example. If you see the vessel in a vertical direction, that is belonging to mesentery. If you see vessel in horizontal, that is belonging to retroperitoneum in general. So once I complete the medial to lateral dissection, then I go laterally. And many surgeons ask me, when you stop the medial to lateral dissection? This is my own anatomy landmark. Here, this part, gerotas and pancreas, body and tail, sometimes spleen. Here is psoas muscle, and here, left. Once I see the left ureter crossing the iliac vessel, then I can stop. Next, please. Then lateral. Here, for lateral dissection, the textbook teaching is come here, then stop, then open this to get into lesser sac, then rendezvous. That is our traditional teaching. But my preference and my teaching is no, just going in this way. Why? Two advantages. Number one, we do not need to change the patient position. Still keep this. Then here, think about, this is mostly a huge amount of fat and omentum. Here is less amount of omentum. So very easy to find out a vascular plane between colon and omentum. So if you just follow this way, you can dissect relatively easily. Next. This is one particular special technique, that is left colic artery preserving D3 lymph node dissection. Yesterday, the patient was 80-year-old, very advanced upper rectal cancer. So I did this kind of operation. Left colic artery preserved. To get better perfusion on the proximal anastomotic segment. So the principle is same. Two hands free. Next. Then TME dissection. Here, what this means, some surgeons utilize the assistant holding the rectum, then pull. I hate it. Why? Even though the TME plane was perfect. But final specimen, look at this. All the mesentery, mesorectum already disrupted. Why? Assistant holding the mesorectum, broken, tearing. So my principle, the rectal side that has the tumor side controlled by myself, my own left hand. Assistant, one hand is traction, the rectum out from the pelvis, very important. And the other hand is counter traction. I do not let my assistant holding the tumor side. Remember that. You have to develop your own TME standardized technique in that way. Next. And if somebody asks me, what is the most important technical aspect for TME exposure? For that, click. Next. There is, yeah. Rectum should be retracted out from the pelvis while the TME dissection is being proceeded. Steady, continuous traction is perhaps the single most important technical aspect. You have to have this. Next. Next. For that, I have two particular techniques. Tips, actually. Here, cotton tape. It's better to have nylon tape to make a knot easily. If you have a thick cotton tape, you cannot get it, or also it cannot be holded by your assistant. So this is my preference. Once I have that, look at this. We can get better exposure in the pelvis. It's exactly the same for my laparoscope. Next. And this is my second tip. Here. In female, many surgeons utilize this, of course. Straight needle. But yesterday I saw the hospital doesn't have this. But so my recommendation, Yashin, you have to prepare this. And even in male, once I release the anterior peritoneal reflection, same suture to lifting up the bladder and seminal vesicle. It helps. Next. This is also very important. Our traditional teaching for TME, starting from posterior, then go all the way down to the pelvic floor muscle. That is the standard traditional teaching. Even now, many surgeons are utilizing that, but I don't recommend that. Why? If you do that, at some moment, you recognize, oh, the space is getting narrow and narrow and narrow. It's inevitable. And also, in terms of plane, anterior and posterior is, I would say, is more straightforward. Why? Anterior, we have uterus, vagina, and anterior peritoneal reflection. In male, we have seminal vesicle, prostate. So it's more straightforward. although the exposure is difficult. And posterior, yes. Here, sacrum, bone, bone, bone. But lateral, what is your anatomic landmark to dissect the TME? There is no anatomic landmark. Surgeon is, once we have this anterior posterior, then it's a kind of imaginary line to make circumference. That is our practice. There is no clear anatomy. So once I released all the peritoneum surrounding the rectum, lateral, anterior, we can get better idea where we dissect the lateral in particular, and also much easier orientation where to dissect. So my TME dissection is posterior dissection first and stop about at the upper rectum, then release all the peritoneum, then having this traction, then is more likely a spiral way. I don't go posterior all the way down. Dissection, then stop. Then lateral. I'm very free. I don't fix just posterior all the way down. Just free to move lateral, left, right, anterior. Then again go to posterior. If you utilize that technique, you will get quite good feeling in terms of dissecting plane. Next issue is this, transection of the lower rectum. Again, very challenging issue. Next. Here, this is my tip. Fully mobilize the rectum at least 2 to 3 centimeters low down below the transecting line. And please ensure the both lips, upper and lower lip, so the linear stapler are securely crossed rectum. For that, good, steady, continuous traction on the rectum is quite essential. And also my own surgeon two-hand coordination. Here, 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 here. That is very important. Next. Next, please. This has voice. This has audio, please. That's okay. Keep continue. This has audio. Okay, here, look at this. This metal is up, and this, the colored tip is posterior. That is completely opposite to the procedure guide. They recommend the other way. But I like this. Why? Two reasons. The metal part is sharp, and colored one is blunt. So if you do in a different way, there is a risk of this sharp tip puncture the rectum, because it's, most of the time it's not visible in your screen because it's posterior. That is number one. Number two is in the very deep pelvis, a lot of fluid, sometimes blood. The metal tip is shorter than a colored one. So sometimes you cannot see whether we are entirely safely crossing the rectum or not. But the colored one is sometimes easily visualized. So that is the reason why I prefer in this way. Two hands coordination. Keep traction gently. Look at this. Can you recognize? I just saw the posterior lip. That is, look at that. Next. Same thing. But I have to check whether there is any puncture. Yes. Then this is my own way to get the transecting line as a perpendicular to the longitudinal axis. Here, for the pushing, then pushing this way. Of course, if it is slightly oblique rather than perfect perpendicular, it doesn't matter. My two hands coordination. I'm trying to see the posterior part in particular. Yeah, I saw it. That guarantee, okay, I'm safely crossing the rectum. Look at this. If very small tissue left, yeah, this case I think is a third. Next, here, again, same thing. This left side pelvic wall, the right side pelvic wall. This is gold color. The tattoo here. For upper rectal cancer, I sometimes utilize tattoo, but mid and low, no, never. Try to make sure the both anterior, posterior, upper and lower jaws are entirely crossing. Again, to get the exposure, traction, my two hands coordination. I can utilize second fire, or sometimes very small tissue left, I utilize a clip. The rationale of safety of utilizing that clip is our appendectomy. Appendectomy, we utilize clip, no leak. That's it. Next. This is several other cases, but you can recognize almost same technique, very much standardized. Here. Here. And here, look at this. This is the way to get more perpendicular angle. But to be honest, now I'm utilizing a robotic stapler. It's much maneuverable and much easier. But yeah, here, look at this. Clip, then cut. Okay, next. Next, please. And clearing the major rectum. Sometimes high anterior section, for example. The one challenging part is how to divide the major rectum. That very ultra low anterior section, there is no mesentery, so we can just apply stapler. But high anterior section, quite amount of major rectum there, so we have to make clear the major rectum in order to apply the stapler. So this is my technique. I start from here about 9 o'clock or 10 o'clock, 3 o'clock, 2 o'clock direction, then coming this way, then stop, then anterior. Next. And tumor localization for safe distal margin. For me, for colorectal cancer, I am aiming to have 5 centimeter distal margin. For mid-rectal cancer, I am aiming to have 3 centimeter distal margin. For low rectal cancer, I am aiming to have 2 centimeter distal margin. But that is my aim. If the real margin is less than that, doesn't matter. So in terms of optimal distal resection margin, still is quite debatable. It's quite different among surgeons. But based on that concept, in terms of my oncologic outcome, is very, very promising. So, and also, mostly, if it is palpable on my finger before the surgery, I do not utilize any fancy diagnostic tool, including scope. Just check using my finger. That's it. But if there is any doubt, okay, we can do scope. And again, tattoo for mid-lower tumor is not recommended because too diffuse, too localized. Next. And one issue is this. If this is an open case, this is umbilicus, right lower quadrant. If this is extended wound on the left lower quadrant, if this is an open surgery, we can bring this proximal colon down to the pelvis. We can roughly measure, oh, this is good for, enough for tension-free. But how can we measure whether this transecting line is good for tension-free? This is my own strategy. Here, this symphysis pubis. Again, this is left lower quadrant. So if I divide here at the pubic bone, symphysis pubis, that is just enough for a tension-free anastomosis at the level of peritoneal reflection. So I'm looking at this. Where is peritoneal reflection? If the transection is 2 centimeters below the peritoneal reflection, I get further 2 centimeters. If it is 5 centimeters below the peritoneal reflection, I have 5 centimeters below. That is my guide, strategic guide. Next. Next, please. Unfortunately, this patient had still tension. So if you have a tension, this is my flow of strategy. Check where the maximum tension located, lateral or medial. Then releasing all the peritoneal adhesions around the mesenteric root. IMV high ligation and dividing the left coronary artery. And this particular patient, the full takedown of splenic fracture was not performed. So I'm trying to do full splenic fracture mobilization with separating this colon from the pancreas as well. Next. Circular stapler. Using a sizer to dilate anus before introducing a circular stapler and passing the center spike through the overlapped linear step line if we utilize more than 2 fires, and counterpushing, you saw the my instrument. And for this is also my technical tip. It is really, really ultra low type of transaction. There is no space, no room to put even 29, 28. So on purpose, if there is a really, really low, I utilize 25. And there is a study in Japan. They are nowadays, 25 is most recommendable size for any low entry section. 25, 28, 29, there is no difference in terms of stenosis. Sometimes if you utilize the biggest one, there is a stretching, the bowel, somehow perfusion is not good, get also to make the colon thinner. So it's not safe. So my routine is 29, but for ultra low, I'm utilizing 25. Next. Interesting case. You will see it. Something happened very soon. Trying to insert circular stapler, wow, punctures. How you manage it? There are several different ways. But this particular case, I decided to resect more here. This is my assistant. This is my left hand. My left hand, assistant. Same thing, same principle. Next. Gentle dilatation of the anus first before introducing circular stapler and counter pushing on the stump. Next. This is last. Here, in the past, our traditional teaching to dissect the posterior part. This is angel's hair. That was first described by Professor Bill Hill. Angel's hair. 10 years ago, until this is the recommendation. Cut through the middle of these hairs. But nowadays changed. Even Professor Bill Hill you have to go innermost layer here and dissect off from the major rectum here. If you divide this, there are two risks. Number one, sometimes you can have a bleeding from the presacral space. Number two, here, there are two layers posteriorly. One is presacral fascia covering the pelvic bone. There is really a parietal fascia in the pelvis. And anterior to pelvic fascia, all the nerves are there. Sympathetic, parasympathetic, particularly parasympathetic nerves. Nervi erugentes. Another, a different name is pelvic splanchnic nerve. And there is a very thin, filmy layer covering those nerves. That is pre-hypogastric nerve. So if you have a plane, there is a risk to injure the nerves. So you have to follow this way. This is the last slide for TME. Thank you very much. Terima kasih. 감사합니다. I have one more talk, CME. So, which is better, to get question now for this or after CME? Huh? So, question first.
Okay.
Okay.
So, okay.
All right, okay. So, my suggestion, this is not a Congress meeting lecture. So, I want have more flexible, free Q&A session. Even very minor, basic questions, you can ask me. Any question?
I'm the first to ask,
Yeah.
Prof. So when the rectal stump is so short, is there any tips to reduce the risk of blowout stump when we insert stapler? If it's so the distance is so short.
The rectal stump is very short.
Yes.
Anyway,
Yeah. Yes. When we want to insert stapler, there's a risk of blowout, just like the one you saw. Is there any tips to reduce the risk?
there is no magic secret to prevent it. Only ways to avoid any sudden, abrupt insertion of the circular stapler head from the below. That is number one. For that, anal dilatation prior to insertion of circular stapler head is quite important to me. And the other is counter pushing while the circular stapler is coming in.
Counter pushing is from below or
No. From the abdomen, from the above. Counter pushing. The device that I showed in my video is actually not reusable, but we use it until broken. But if you do not have that, you can utilize any instrument for counter pushing.
any other?
Maybe another question.
Thank you, Professor. My name is Dr. Tia from Adam Malik Hospital. I want to ask you, do you do the TME for the upper rectum tumor, or maybe you just do the partial mesorectal excision? And then the second question is, do you routinely do the diverting stoma for every after you do the TMA or the PMA, or maybe for the only the lower, or maybe what is your preference to do the diverting stoma in the rectal tumor? Thank you, Professor.
Thank you for very important questions for rectal surgery, rectal cancer surgery. The first question, no. Upper rectal cancer, I don't do TME. It's tumor-specific mesorectal excision, means the very distal part of the mesorectum, I don't resect. Just about 5 centimeter, as I told you, distal, then transect the mesorectum at the same level of my transecting. Low rectum, of course, there is little, almost no mesorectum, so it's just naturally we can do TME, but mid-rectum is still debatable. Among surgeons, some surgeons prefer to TME, some other surgeons still do tumor-specific. Me is I'm not doing TME. Even mid-rectal cancer is about 6 to 10 centimeter, for example. If there is 10 centimeter high, I don't do TME. I just do tumor-specific mesorectal excision, because my aim is having 3 centimeter distal margin. So based on my own data, utilizing such strategy, I don't think I have any oncologic risk related to that policy. But still, majority of surgeons, I would say 2/3, 70–80% of particularly the European surgeons, mid-rectal cancer, they strongly insist TME. But my practice, no. And regarding your second question, that was, again,
You use the protective ileostomy.
diverting stoma. There are now 2 issues regarding diverting stoma. Number one is ileostomy versus transverse colostomy, number one. Number 2, selective or routine. My practice is almost always I utilize ileum on the right low quadrant, and I'm not doing routine, selectively. So how selective, what selective is selective? In Korea, we had our nationwide multi-center data. What situations we have to have diverting stoma? 3 risk factors. Male, pre-op radiation, low rectal tumor, not low anterior resection, low rectal tumor. If the patient has all 3 factors, we strongly recommend diverting stoma, 100%. If patient has 2 factors, it really depending on the surgeon's decision, whether the dissection was difficult, bleeding was much, several other factors, or patient has any comorbid disease or not. So I would say if the patient has two such factors, about 2/3 or 60–70% of my case, I would do proximal diversion. If patient has 1 factor, also is surgeon's decision, considering several other factors as well. I My practice, about 20-30% is divergent. 70-80% no divergent. So that's my answer. Yesterday, the patient was upper rectal cancer. It's about 3 centimeters above the peritoneal reflection, and we transected about another 3 centimeters below the peritoneal reflection. Male, no radiation, only one factor, that is male. So, and the transaction was done in 2 fires. So I didn't divert. In terms of number of firing, between single fire and 2 fires, there is no difference. Some paper says 2 fires has slightly higher risk, but my data and many others' data, between single fire and 2 fires, no difference. But if the firing number is 3 or more, it's definitely a risk. So if I transect rectum with 3 or more fires, I divert. And in the past, I tried to do single fire as much as possible. That was about 15 years ago. But I stopped on purpose. I do not try to resect in a single fire. Why? The evidence. Single fire versus second fire, 2 fires is similar. And also, somehow, single fire has its own risk. Think about this. If you transect the rectum in a single fire, if the rectum is quite bulky, large, you always see the line is not straight. It's like curved linear. It's more chance of dog ear. So if I feel single fire is not easily done, I just utilize 2 fires nowadays. And also here, if I transect the rectum in a single fire, there are 2 dog ears, proximal and distal. Which is more risky? Which, proximal or distal? Distal. That is always the most risk part. Why? That is related to the stapler mechanics. I checked with 2 major companies, Eticon and the other company. The engineers agreed, yes, the distal part is the weakest part. So, on purpose, I try to include the distal dog in the circular stapler. You understand what I mean? Yes. If I utilize the 2 fires, for example, I try to get the overlapped area. But if I utilize 1 single fire, I try to get this dog ear in the specimen to avoid that risk.
Thank you, Professor. I want to ask another question. Did you do any intersphincteric resection for very low rectal tumor that include the internal sphincter? And then have you been the Hanson method for the anastomosis? Maybe if I get that case that you presented before, if I leak the stapler, maybe I will do the Hanson method for that. Or maybe have you been maybe like some pull through? You take out the proximal stump over the anal, And then the next question is, do you prefer end-to-end anastomosis or side-to-end anastomosis? Thank you, Professor.
That is also excellent questions. Today, I didn't prepare intersphincter resection videos or any slides, but intersphincter resection is one of my high expertise area. I have done more than 200 intersphincter resection. Means dissect the lower rectum and also upper anal canal through the intersphincteric space. Then transabdominally. That's my current practice. Then the distal part is transanally. I am aiming to have 1 centimeter distal to the tumor. Burn the mucosa, submucosa, then dissect the rest part of intersphincteric dissection per anal. Then get rendezvous, transabdominal and transanal, then bring out the specimen through the anus, cut, then coloanal hands-on anastomosis. Hands-on anastomosis, I prefer side to end. I don't have my data. Between end to end and side to end, short-term outcome slightly better with side to end in terms of low anterior section syndrome score, but long-term is not much different. But my practice is side to end. Side to end means bring the colon out, then turn in this way, then about 3 centimeters from this colonic end, I cut, then side, colon side, and anus, side to end anastomosis by 3-0 vicryl. And that is for almost all cases with intersphincter resection, and also for ultra low anterior resection, I prefer to do side to end anastomosis as well. Ultra low anterior resection, if you look at the literature, what is definition of ultra low? For example, in Malaysia, they thought, oh, this is ultra low. But my definition, no, this is just standard low anterior section. It's not ultra low. Ultra low, there is no common consensus whether this is just standard low or ultra low. It is variable among literature, but my own definition of ultra low is if the anastomosis is in the anorectal junction, that is pelvic floor muscle, or below. That is my definition of ultra low. So in such case, I do prefer side to end anastomosis. Good question. Pull through. No, I haven't done yet. That means the bring out the colon, then transect, do not suture, but 1 week later, excise the outbulging prolapsed part, then do hands-on anosmosis. My colleague, he is doing that technique, and he told me it's quite promising. Now more and more surgeons are adapting that technique in worldwide. But one problem is we have to keep the patient in the hospital for many days, more days.
Okay, thank you for the questions. Please give applause first for Professor Kim
Thank you
Son
very
Han.
much.
Okay, next we continue to the third scientific about tips and trick in total mesorectal excision or TMI.
CME, complete
TME.
colon excision.
Complete,
Next.
sorry.
Next slide, please. There are some confusions in the literature. What is CME? What is CVL? What is D3? And originally, CME was reported together with CVL, central vascular ligation. CME is preserving of the mesocolic plane. CVL is high tie at the origin. Yes, two components. Next. This lymph node dissection at the very high position at the origin is almost a similar concept as Japanese D3 lymph node dissection. Next. So, CVL, central vascular ligation, is not an issue of high versus low, but is an issue of how high, high tie, high ligation. Next. The definition of D3 resection is removal of all lymph nodes around the origin of the feeding arteries. This indicates that a high tie does not necessarily mean D3 resection because the central lobes may remain when the artery is divided at the level of this blue line. This illustration clearly shows a high tie with D2 resection. After right colectomy, the central lobes are still left in sight around the feeding arteries, meaning that there is a risk of understage due to 3 to 5% of skip metastasis to the apical nodes. This is one rationale that D3 resection is recommended in an advanced T-staged cancer. I want to introduce one particular case operated several years ago. When I entered OT, my fellow reported me that he was doing perhaps D3. But after scrub, I found it was D2 when I traced the divided end of the ileocolic artery and vein here. So he believed, so he did high tie, but that was not D3. So I remove the remaining central lymph nodes. This is SMA and SMV here. Next. 2 nodes were positive among the 8 additionally resected central lobes, meaning that the initial stage was N1B in D2 dissection, but the final stage was N2A in D3 dissection. For me, it was not only an issue of stage migration, but also an issue of R0 versus R2 resection. This patient was disease-free at 42 months. Next. So, what is the correct plane for D3 dissection? Number 1, 2, or 3? ileocolic. This is done by my colleague, Jin Kim. This is the line for D3. Lifting up the pedicle is very important. This is SMV. Not sure yet. Whether this is branch or SMV, not sure. Expose more. Looks like artery here. This is not SMV. This is ileocolic vein. The key is here. Good traction on the mesentery. Next. Next, please. This is my operation. I prefer monopolar seizure. Good traction. 2 hands free. Here, this is my line for D3. I'm trying to expose the anterior surface of the SMV. That is always the initial landmark here, duodenum. 2 hands free. Final exposure is my left hand, non-dominant hand responsibility. Here, artery, vein, pancreas, duodenum. Everything is under control, my 2 hands. SMA here, ileocolic artery. Half of patient ileocolic artery behind, another half is in front. I found one lymph node, so I separately removed while I was approaching to the midcolic vessels. So at this moment, I don't know what in terms of vascular anatomy. I don't care. I just try to follow the important anatomy. That is SMV, and this is SMV and artery. Until the final dissection, we cannot say this is midcolic or this is right colic. We cannot say it because there are so many variations. But for my practice, it doesn't matter. So here, what I showed is here, there's a falciform ligament. There is roughly my anatomy orientation. Oh, I am in the middle. Again, this is SMV, and perhaps this patient is right colic artery, But I'm not sure whether this is separate two branch of mid-colic artery, because 70% mid-colic artery is common trunk, then right and left, and 30% the right and left branch is separate. But this is as SMA. So name itself is not much important. The key point is here. The transverse mesocolon should be retracted, not upward, anteroward by your assistant. If you have this upward traction, all vessels is oblique. But once you try to, like this, you can approach. It's like a book open. And this is common anatomy. Here, if you see the vein in this way, that is gastrocolic trunk. If you see another vein slightly further high up on the right side of the screen, there is mid-colic. This is a landmark vein during CME. Once you see this, you have to separate here, this vein. This is colic branch of the gastrocolic trunk. It's very constant. So during duodenum and pancreas separation from this, you will see this. If you see this, that is our specimen site. So don't care about this pancreatico-duodenal branch. Here, colic branch. Anyway, we have to ligate this. This gastrocolic trunk, colic branch, pancreatico-duodenal, and gastroepiploic is somewhere there, here. So once you divide this, there is a fatty tissue here. If you go this is wrong plane for standard CME, right colectomy. This is here. This fat is infrapyloric. The gastric surgeon tells this number 6 lymph node. So between this fat and colon behind is a vascular embryologic plane between foregut, stomach, and our midgut. Next.
Why is the mid-colic artery important for oncological right colectomy? Besides the cecum, for all the other segments of the right colon, the middle colic artery is one feeding artery for the regional lymph node metastasis.
These videos show how I approach to the root of the middle-colic vessels and the gastric colic trunk. After dividing the ileocolic vessels, the dissection continues cephalad along the anterior surface of the SMV. In order to expose the root of these vessels, upward and anteroward traction on the transverse colon mesentery is the key. The gastrocolic trunk
connected to the SMV is visualized here. And here.
Again, this is right colic branch. That is a landmark for dissection. So my standard CME CVL, iliocolic, right colic, and mid-colic artery root. If the tumor is hepatic fracture or proximal transverse colon. If tumor is locating ascending colon or cecum, only right branch of the mid-colic artery. That is my extent of dissection. But next, click. If I see infrapyloric or gastroepiploic lymph nodes visible on CT preoperatively or detected intraoperatively, I do extended CME. Next. The extended CME, gastrocolic trunk is the landmark. Here, gastrocolic trunk is again 3 branches. There are several different names. I don't care. Right colic or accessory right colic. It's colic branch. So one is going to the colon. The other going to the stomach, gastroepiploic. The other going to the pancreas. So here, right colic, right gastroepiploic, and pancreatic.
This is my.
Okay, go ahead.
This is my standard CME plane around the gastrocolic trunk. After ligating the right colic vein, then the infrapyloric nose-bearing fatty tissue is being separated from the transverse colon behind.
This way. Pancreas and infrapyloric. Colon behind. Next. Next, please.
This video shows a laparoscopic CME with extended D3 lymphadenectomy for advanced hepatic flexure cancer, addressing the surgical technique of
So plane
infrapyloric
will
node
be
dissection.
in this way, not
A
this way.
52-year-old male patient with
Hepatic
occlusion
flexure.
symptoms was diagnosed with a CT3 and positive hepatic flexure adenocarcinoma with a suspicious liver metastasis at segment 8.
The following CT images show the anatomy of the middle colic vessels and the relationship with suspicious middle colic vessel lymph nodes and infrapyloric lymph nodes. Trocar and surgeon's position are here reported.
The ileocolic groove is open with assistant's help. The superior mesenteric fold is exposed by the assistant while the surgeon opens the root of the right mesocolon. The superior mesenteric vein and the ileocolic vessels are exposed. This patient had a posterior ileocolic artery. Once identified, the ileocolic vein was isolated and divided at the root between homolog clips.
So again, the landmark
Also, the
is
ileocolic artery was
here,
identified,
SMV.
isolated and divided at the root between clips.
This patient's artery is behind.
The right colic vein is a landmark
Yeah.
for correctly
This is a
identifying the
landmark.
plane between the transverse mesocolon and the pancreas, which is then carefully dissected.
Final exposure, my left
The
hand.
dissection
Same
proceeds
principle.
along the anterior surface
Two
of
hands
the
free.
superior mesenteric vein and extends to
This
the
is
transverse colon
Let,
for optimal
another anatomy
exposure.
is midline. Because the
The common
middle colic
pedicle of
artery
the
is
middle colic artery is
about the
identified
midline.
and dissected for optimal exposure. Here is visible the right and left branch. The right branch is then isolated and divided between clips. In this case of hepatic flexure cancer with suspicious infrapyloric nodes, also the left branch is isolated and divided between clips. The gastrocolic trunk of Henle is identified. The The right colic vein and the anterior superior pancreaticoduodenal vein are easily identified in this patient. The right colic vein is isolated and divided between clips, taking care to preserve the anterior superior pancreaticoduodenal vein. The common trunk of the middle colic vein is identified, isolated, and divided between
This
clips.
patient is middle-colic vein has a common trunk with gastrocolic trunk.
At this
About
point,
30%
the
of
infrapyloric
patients
region is approached
has it.
and a suspicious node is identified and dissected with monopolar scissors and ultrasonic dissector.
So this is infrapyloric area here.
Another suspicious infrapyloric node is identified next to the right gastrocolic vein,
This is
which is
gastroepiploid
isolated and dissected between clips.
here. And very soon we can see gastroepiploid artery as
The
well.
infrapyloric nodes are dissected in toto, and the proximal segment of the right gastrocolic vein is dissected between clips.
So this
Dissection
anatomy you may
proceeds
not
above the pancreas on the right side.
very familiar. Not many surgeons know about this anatomy particularly.
A middle colic node is identified and dissected with an ultrasonic dissector.
So if you are not
Dissection
familiar with
continues above the
anatomy
pancreas on the
around
left side.
here, of course we can approach from
stomach's
the
parietal
above. It
curvature
doesn't
can
matter.
be
But
seen.
for me,
The
I'm
omentum is
much
dissected along
confident
the transverse
all the
column,
anatomy, so
and
I
the smaller
just
sac is
continue
accessed
the
from
medial to
above.
lateral dissection.
The right gastrocolic vessels are then
So
isolated and
omentectomy,
dissected between
usually
clips.
I do not
The mobilization
include
of
the
the
omentum
transverse
for
mesocolon proceeds
right
cranially
colectomy
with hepatic
if
flexure
tumor is
takedown.
locating ascending colon, for example. But tumor is hepatic flexure or transverse colon, I do
A suspicious gastrocolic node is
limited
identified along the greater
omentectomy.
curvature
It's
and
about
dissected with the
5
specimen.
to
Operating
10
time was
centimeter
150
away from the
minutes. The final pathological
tumor,
report
I just
shows
resect. But Professor Hohenberger, who originally described this CME, he do total omentectomy, but I don't believe it. So again, there are two different plane, standard plane. Next. Next please, extended CME plane to include infrapyloric and gastroepiploid. And about half of momentum I resect. Next. I was particularly interested in this issue. So we did systematic review, and not many papers found, only 9 papers. Next. The lymph node positive rate is very variable from less than 1% to 22%. But, next, here, these 3 are only papers in a prospective design. Look at this. These 3 papers, quite high. So this is very warning data. So might be higher incidence than our thinking. Next. And I found only 1 paper. What is the risk factors of having metastasis to this area? Endoscopic obstruction, signet ring cell, high CA, and M1 stage. So if the patient has metastasis to this area, infrapyloric or gastroepiploid, his tumor is very aggressive. So it is between stage 3 and stage 4 already. Next. I have, okay, we have enough time, don't worry. 2 more topics, transverse colon cancer and splenic fracture cancer. Those are still under-evaluated and less evaluated areas. Transverse colon, transverse colectomy. Who ever done transverse colectomy? Maybe not. This is my procedure and technique. Next. When do I perform transverse colectomy? Very few indications. Cancer locating in the middle of the transverse colon, and at the same time, patient has long redundant transverse colon. In this case, I do transverse colectomy rather than extended right or extended left or subtotal type of. Next. Next. Yeah. So transverse colon, mid-colic is the key. The other vessels, no. That's the rationale that we can do transverse colectomy. Because this side is not our regional lymph node for transverse colon. Next. And this is data. Next.
72-year-old male patient was diagnosed with middle transverse colon cancer. Abdominal CT scan shows eccentric wall thickening at mid-transverse colon with multiple enlarged regional lymph nodes. This is our operating room setup in the beginning of laparoscopic transverse colectomy. In the Trendelenburg position, the surgeon and the camera assistant stands on patient's left side, and the assistant stands on patient's right side. The omentum is placed in an upward direction, and the small intestine is pushed down to the caudal direction.
Tumor.
Then duodenum and tissue around the middle colic vessel is exposed.
Not many surgeons know whether we can directly approach to the middle colic artery.
Dissection starts around the origin of middle colic
Above the
vessels,
duodenum,
using the dissector
that is
with
the
left hand and a suction
target
device
anatomy.
equipped with monopolar electrodes with the right hand. This suction device offers the advantage of bleeding control and maintaining clear window during dissection, with the ability to perform both suction and cauterization simultaneously. Likewise, any other oncologic
Yashin,
laparoscopic
I
colectomy
recommend
performed
this
in our
device.
institute, central vascular ligation,
Olympus.
incomplete mesocolic excision, and medial to lateral dissection are routinely performed. Clear lymph node dissection around the middle colic artery is required because all lymphatics of mid-transverse colon cancer are drained only through the middle colic artery. Proximal transverse mesocolon is
Duodenum.
detached from duodenum and pancreas along the embryologic plane. With continuous dissection, gastrocolic trunk, middle colic artery, and middle colic vein are identified.
This is the most typical.
All these named vessels
Middle-colic
are
artery,
divided with the
gastrocolic
scissors
trunk,
and
and
ligated
middle-colic
with
vein.
endoclites in the same fashion.
Almost 70–80%. This.
First, the middle colic artery is skeletonized with sharp dissection, then ligated and divided at the root. Then gastrocolic trunk is skeletonized with sharp dissection, then ligated and divided.
Look at this. Anterior retraction.
Middle colic vein is also ligated and divided. After the vessel ligation, the medial to lateral dissection is continued, likewise with other laparoscopic colectomy.
suction and monopolar cautery at the same time. And suction power is very easily controllable. So it can prevent any sudden decompress of gas leak. This is excellent instrument. Everybody who watched my operation in my OT, they like it. Then once they return, they buy this. And this device, when I came to Malaysia, my fellows
The right gastroepiploid
gave this
artery,
as a gift.
which is a branch of
So I brought this
gastroduodenal artery, is
to Malaysia.
preserved.
Now,
And if infrapelvic
Malaysian
lymph node
surgeons at
growths mainly
University of Malaya,
involved
they
first
like
line
this.
lymphatic pathway are not routinely dissected.
So this is the area here. This is gastroepiploid. This is infrapyloric. If you dissect this below, that is extended. If you go above, that is standard. Here. Look at this. It's embryological plane. Can be separable. Here. Yeah. This is number 6, infrapyloric. So this patient, even though the tumor was located in the mid-transverse colon, I did not see any lymph node on CT around infrapyloric or gastroepiploid. And I didn't find any lymph node,
The omentum is
prominent
divided
lymph node
and
during
detached
operation.
below
So
the gastro-
that's the reason why I did standard CME transverse colectomy. Okay, so mobilizing this, then did transverse colon resection extracorporeally, then anastomosis. That is the next procedure. Next, can you go next? But this is transverse colectomy with extended CME. It's different from the previous. I think this has audio, no? I'm sorry. That's okay, all right. And I just want to briefly show this Da Vinci SP. I have 2 specific indications, suprapubic right colectomy and intersphincter resection, because I can put the single port on the stoma side. From sprain fracture to pelvis can be done. Next.
Exploring the abdominal cavity, the endoscopic tattoo was identified, confirming the mid-transverse tumor location. The caudal surface
Very long redundance.
was lifted
So
upwards
one of my indication of transverse
and was
colectomy.
opened above the duodenum. The anterior
This is
pancreaticoduodenal
here.
space was dissected.
Single port placed here. And I have one additional. This is 3 centimeter. This for my assistant, bedside assistant. Pancreas. So directly approach to the mid-colic vessel. Same thing. And yesterday I told Dr. Yashin, in Southeast Asia,
The right
our
branch of the
region,
middle-colic artery was identified.
SP is not
divided between polymeric
only
groups
one system,
according to the
if I'm not
principles of
mistaken.
tissue
In
lymphadenectomy.
Philippines now,
Here
that is
visible
Chinese
detail of the
single port.
navigator hologram showing
But
the entrance of the
My
clip.
perspective of single port robot, many of my multi-port robotic surgery will be moved to single port. If single port robotic
Column packing
stapler
of the middle colic vein was
is
exploring
available.
the abdominal
Now
cavity. The endoscopic tattoo
it was
identified,
just
confirming
released,
the mid-transverse
and
location. The caudal surface
a
of
few months ago, Korea single port stapler, Da Vinci, is now being utilized. So it will be really a game changer. for the future. Not very far future, in the very near future. Believe me. So you have to keep the knowledge on this. Next. Next, please. Next. Then splenic fracture, another hidden area. Next. Many issues. Next. So under-evaluated. And even among experts, much different opinions. Next. For example, what is the definition of splenic fracture? There are several different opinions. Next. And what type of surgery we need? Many different. Next. But I'm particularly interested in this oncologic lymph node dissection because it's quite challenging. Why? Next. This is an example. In one surgical atlas, this is tumor here. This is extent of resection. It's completely wrong. Why? They didn't remove any lymph node here. This is whether this is distal transverse colon or splenic fracture. The mid-colic artery is most important, but it's wrong concept. This is a common error. Next. Because splenic fracture has dual pathway. Next. Next, please. So to approach the splenic fracture, again, I prefer medial approach. Next. Next. Here. Advanced tumor attached to proximal jejunum here. Next. Here. So splenic fracture cancer approach to the IMV first. That is the way to do oncologic resection. Here. Same principle. Here. Get into lesser sac. Pancreas. This is the left colic artery here. IMV. I'm trying to do D3 type of lymph node dissection around the IMA. But if I decide the extent of resection in this way, I have to preserve the superior rectal artery. For that, the superior rectal artery preserving left colectomy. Here, IMA, superior rectal artery, left colic artery. Actually, the superior rectal artery is continuation of IMA, we all know. The name is just changing when the IMA is crossing the iliac vessel. Before iliac vessel is IMA, still IMA, by definition. After crossing the iliac vessel is superior rectal artery. So for this location, the dissection here around the splenic fracture is different from our routine splenic fracture takedown for low entry resection. Why? I have to include the omentum. Because tumor is there, we have to include the omentum. So my dissecting plane is outside of the omentum. Then, now I'm trying to do D3 type of dissection on the mid-colic artery. I change the position to the patient left side to approach the mid-colic artery. Pancreas, somewhere there. maybe at the time my knowledge was a little limited because it is a chance of gastrocolic trunk rather than midcolic pain. Okay, next. This is specimen, left colic artery, mid colic artery, vein, lymph node, IMV. Next. And sometimes after left colectomy, I mean the superior rectal artery preserving, we can do intracorporeal anastomosis. Sigmoid, transverse colon, suture. Next. Of course, sometimes we need subtotal. When I do perform subtotal for spring fracture cancer, proximal colon is not evaluated, of course. And colic anastomosis is not feasible, safe, because ileocolic anastomosis is always safer in terms of leak or whatever. Next. This is my own data based on that concept. Next. So my own data is one of the best oncological outcome among the literature. I think it's the end of my talk. Next. Thank you very much.
Thank you very much, Professor. Maybe we continue to the second session for the question. Is there any question? Okay.
Thank you, Professor. I want to ask, do you routinely reconstruct the vasculature from the CT scan preoperatively, or you just find it in the intraoperatively based on the common variation of the vasculature? Thank you, Professor.
Yeah, I don't do routine CT reconstruction for vascular anatomy. Why? Because if I just follow the key vascular anatomy like SMV and SMA, one example is sometimes I see artery after ileocolic artery ligation during further cephalot dissection. If still, I'm not sure whether there is mid-colic artery or right colic artery. But it doesn't matter for me. I have to ligate it. Otherwise, I cannot develop the plane. So ligate it. So continuing, then if I see mid-colic artery, oh, this is right colic, that was right colic artery. Otherwise, no other chance. So that is just an example. But venous anatomy is, of course, more complicated. But even venous anatomy is so variable. So just follow here. But gastrocolic trunk is almost common, is always existing. So that is landmark. Once I saw it and try to mobilize the transverse mesentery, colonic mesentery, to separate from the pancreas. Otherwise, I cannot bring out the specimen. So whatever vessels I see, I just ligate it. But if you use 3D reconstruction prior to surgery, that I agree that might be beneficial for the beginners, but even though you saw those vessels before the surgery, I believe that still the technical demanding is almost the same. So for your question, my answer is no.
Okay, maybe we can get one last question.
Thank you, Prof. Is there any tips on dissection on SMA or SMV to prevent accident? So how to dissect along the plane around SMA and SMV? Is there any tips to do it?
So SMV, I would say, is relatively easy to expose the anterior surface. Why? Because of the color. The SMV is almost always is like bluish or purple color. You can see it. Only one consideration is if you have a good traction on the iliocolic pedicle, for example, particularly in thin patient, the entire SMV and SMA is also tenting. So if you do not recognize that potential risk issue, you may just cut the SMV because you thought this is iliocolic vein. So in terms of exposed SMV is relatively easy. But SMA, the current consensus for D3 or CME right colectomy, we do not need to expose the anterior surface of the SMA. Even if there is some fatty tissue covering the artery, we do not touch it. But SMV is different. SMV is no lymph node, only fatty tissue. But in order to follow the correct plane, anyway you have to expose the anterior surface.
Okay, maybe is there, no more question? Okay, maybe we can sum up it for the question. Thank you so much, Professor Kim.
Thank you very much.
And thank you, Dr. Yasin, for the splendid presentation. And maybe...
Thank you, Mr. Mutiara, and thank you, Mr. Chongkai. Thank you again.
Okay, thank
감사합니다.
you so much. 감사합니다. Okay, Professor Kim, maybe you can stay in front with Dr. Yasin. Okay, as a token of our sincere appreciation, now we would like to present certificate of appreciation for our distinguished speakers. Maybe we can ask Dr. Mutiara to present the certificate of appreciation for our speakers. Maybe the first one is for Professor Kim. Please give applause for Professor Kim. And the next one for Dr. Yasin. Please give applause for Dr. Yasin. Maybe we can ask. Maybe we can, wait, excuse me first. Maybe we can ask Dr. Jongkai to join in the front and we can take a picture with Dr. Jongkai. Okay, before concluding today's program, after this photo, we invite all the distinguished speaker, guests, and hospital management and all participants to join in a group photograph. Please join us in front. These all the doctors. Please all the participants to join us in the stage. Okay. Dr. Adrian, Dr. Adrian. Pastor, yeah. Okay, maybe Dr. Catherine. Okay, that's good. Okay. Sarangeo.